Welcome back to the Deep Dive. Today, we are putting on our detective hats. But we aren't solving a crime.
No.
We are solving the mystery of the human body.
Hmm?
We're diving deep into, really, the fundamental toolkit of nursing.
Yeah.
The health assessment.
And honestly, detective work is the perfect analogy for this. It really is. Because when you look at the source material we have today, which is a really comprehensive set of educational slides on this, it becomes so clear. This isn't just checking boxes on a form. It's a systematic method of data collection and, well, analysis. It's the bedrock of everything that happens in a hospital.
Exactly. I think there's this massive misconception that an assessment is just, taking a blood pressure and asking, does it hurt?
Mm.
But the sources make a really interesting distinction right off the bat between what a doctor does and what a nurse does. It's not the same job, is it?
It's definitely not. And this is so critical for setting the stage. The medical assessment, the one the doctor, the nurse practitioner does, is focused on the disease.
The disease itself.
Yeah, they're looking for the pathology. They want to find the pneumonia, the fracture, the diabetes.
They're fixing the broken part.
But the nursing assessment, that is focused on the response to the illness. It kind of shifts the lens from biology to biography in a way.
I like that.
So the doctor diagnoses the fracture, but the nurse is assessing the pain, the mobility, the anxiety, and how that person is going to manage walking up their stairs at home.
I love that distinction. It's about planning patient-centered care.
Yeah.
So you're gathering clues to figure out how this human being is coping with what's happening to them.
Precisely.
And to do that, you need a very specific set of tools and a clear understanding of the context.
You do. You can't just walk in blind. The sources actually lay out this context of assessment really clearly. It's not a one-size-fits-all thing. It's more of a landscape of different assessments for different moments.
Okay, let's walk through that landscape then.
Yeah.
The slides mention a few types, starting with the big one, the comprehensive assessment.
Think of this like a wide-angle lens on a camera. The comprehensive assessment is the deep dive, pun intended.
Right.
This usually happens when a patient is first admitted to the hospital, a clinic. It involves a complete health history and a full head-to-toe physical check.
So this is where you establish the baseline.
Exactly. You can't know if a patient is getting better or worse if you don't know where they started. You need that full picture, physical, emotional, social, all of it.
But you obviously can't do that every single time you walk into the room. It would take forever.
Right, no. That's where you switch to the zoom lens. We call that the focused assessment.
Okay.
And this is when you zoom in on a specific problem. So let's say a patient comes in specifically because they have a sharp pain in their knee.
Got it.
In that moment, you aren't necessarily going to spend 20 minutes asking about their distant cousin's glaucoma,
Right.
Not unless it's relevant. You're focusing on that specific topic, that body part. You address the immediate problem.
That makes perfect sense. It's about efficiency and triage. And then the sources mention a shift assessment. Is that just doing the same thing over and over?
It's monitoring. It's really just monitoring. And this is probably the most common type for bedside nurses. It's an ongoing assessment conducted each shift to detect changes from that baseline you set earlier.
So it's playing spot the difference.
Ideally, yeah. You're looking for alterations. Is the patient more confused now than they were 4 hours ago? Is their breathing more labored? And then you have your follow-up assessment and your screening assessment.
Right.
Follow-up is just rechecking a problem you already found, like seeing if a fever went down. And screening is a short exam, like a blood pressure check at a health fair to prevent disease.
Catching things before they become a chief complaint.
Exactly.
Okay, so we have the when and the what. Now let's talk about the who. The source material has a slide that specifically breaks down the responsibilities of the RN versus the LPN. And it feels like there's a pretty hard line drawn there.
There is.
Yeah.
And this is a legal and professional distinction. The RN, the registered nurse, is the one responsible for that big comprehensive assessment. But the key words here are analyze and plan.
So the RN is the architect of the care plan.
Yes. The RN collects data, sure, but their primary role is to analyze it to develop a plan of care. Now, the LPN, the licensed practical nurse, plays a crucial role, but it's a different one.
How so?
The LPN collects data both subjective and objective, and they need to be able to distinguish normal from abnormal. But, and this is the big but, they report those findings to the RN.
So the LPN is gathering the evidence, sort of filtering out the noise to say, hey, this is abnormal, but they hand that evidence over to the RN to decide what it means for the big picture.
That's a great way to put it. The source says the LPN contributes to the plan, but that high-level analysis and the initial comprehensive assessment, That belongs to the RN.
Okay, let's get into the evidence itself. We keep saying data, but in nursing, data isn't just numbers. It's split into two huge categories, subjective and objective. And the sources gave us a mnemonic that I actually laughed out loud at, but I know I'll never forget it now.
Oh, I know the one you're talking about, the I sign him symptoms mnemonic.
Yes, I sign him symptoms. It sounds like a bad indie band name, but it totally works. Break it down for us.
So it's all about where the information comes from. Let's start with subjective data. This is what the patient tells you. It's the symptoms. The mnemonic uses HYM, HYM.
Which stands for?
It stands for him, as in the symptom is something only him or her, the patient, knows about.
Okay. So if I say my stomach hurts, that's subjective.
Correct. Only you know it hurts. I can't feel your pain. Nausea is another classic one.
You can't measure nausea.
Exactly. Or itching. I can see you scratching, but the sensation of the itch, that's all you. It's your story.
Got it. So then we have objective data, which connects to the sign part of the mnemonic.
Right. Sign GN is something the nurse can detect. Even if the patient is unconscious, I can see a sign.
So if the patient says, I feel itchy, that's subjective. But if I look at their arm and see a bright red rash,
That is objective. That's a sign. Vital signs, lab values, the color of a wound, the sound of a heart murmur, those are all measurable, observable facts. That's objective data.
it seems like the goal is to marry the two, right? To see if the story matches the facts.
That's the investigation, exactly. And the sources also mention primary versus secondary sources really quickly.
I assume primary is the patient.
Correct. Primary data is straight from the patient. Secondary is from anyone else, a family member, caregiver, even the medical chart.
So if wife tells you he fell down the stairs, that's secondary data.
Yes. And it's valuable, especially with kids or patients with dementia, but you have to remember it's filtered through someone else's perception.
Okay, so we know what kind of data we're looking
Right.
for, signs and symptoms. Now we have to actually go get it.
Yeah.
And that starts with the interview.
Mm-hmm.
The source material really emphasizes that before you even touch the patient, you have to build a history. And step one is pretty basic. Introduce yourself.
It sounds so simple, doesn't it? But you're about to ask a stranger very personal questions. You have to establish professional rapport immediately. You can't just barge in and start poking.
It's about trust,
Mm.
and the way you ask questions matters too. The sources break down 3 styles: open-ended, closed-ended, and directive.
It's like a funnel. You start broad. An open-ended question is something like, so what brings you in today?
You're inviting a story.
Exactly. You want to see how they prioritize the problem. But sometimes you need to narrow it down, so you switch to closed-ended.
The yes or no questions. Does this hurt?
Right. Have you had a fever? These get you specific facts. And then there's directive.
What's that for?
That's when you need details. Describe the drainage, point to exactly where it hurts. You're guiding them.
Okay, so we're interviewing, we're getting the biographical data name, date of birth, all that. But then we get to the chief complaint, or CC. The slide has a golden rule about this.
Yes. Use direct quotes.
Why is that so important? Why not just translate it into medical speak right away?
Because translation involves interpretation, and you might get it wrong. If a patient says, my tummy feels like it's exploding, you write that down, word for word.
Because exploding captures the intensity in a way that distension doesn't.
Exactly. It captures their perception, and if they have 5 different complaints, you ask them, what is the main reason you came in today? You need to know what's bothering them the most.
Okay, once we have that main complaint, we have to drill down. And the source gives us another acronym, a real classic.
Yeah.
OLD CARTS.
Oh, yeah. OLD CARTS is the absolute framework for symptom assessment. If a patient has a symptom, you run it through OLD CARTS to get the full profile.
Okay, let's run through it. Say a patient has back pain. How do we apply OLD CARTS? Let's start with O.
Onset. When did it start? Was it acute, like a sudden snap, or was it gradual
L.
location? Where is it exactly? Lower back? Does it radiate? Does it travel down your leg?
O.
Duration? How long does it last? Is it constant, 247, or does it come and go? Characteristics. The descriptive part. What does it feel like? Sharp, dull, burning. The words they use are huge clues. Aggravating factors, what makes it worse? Bending, sitting. Relieving factors, the opposite, what makes it better? Lying flat, a heating pad. Treatments, what have you tried already? Ibuprofen. And more importantly, did it work?
That's a key piece of data right there.
For sure, which leads to S severity, usually on a scale of 0 to 10. How bad is it right now?
So by the time you finish OLD CARTS, it's not just back pain. It's acute shooting pain in the lower back, started yesterday, radiates to the left leg, 8 out of 10 severity.
That is actionable data that tells everyone exactly where to look.
Before we move on, the history section also lists a few other things we need.
Yeah.
Past health history and family history.
Right. Context is everything. Past health history includes medications, and the source specifies, not just prescriptions. You need to ask about over-the-counter drugs and herbals.
Because herbal stuff isn't always harmless?
Right. Not at all. It's chemistry. St. John's wort can interact with heart meds. You need the dose, the frequency, all of it.
Then you check allergies.
Food, medication, and environmental stuff like latex.
Latex is a big one in a hospital.
It is. You also want to know about previous surgeries, and family history is basically looking for genetic clues. Alzheimer's, cancer, diabetes. If it runs in the family, we need to know.
Okay, we have the history, we have the subjective data, the HIM. Now, we've physically examined them. We're looking for those signs, the objective data, and there seems to be a very specific sequence here.
There is a standard toolkit. The 4 techniques are inspection, palpation, percussion, and auscultation.
Let's take them one by one. Inspection.
That's visual examination. It starts the second you walk in the room. It's not just looking, it's active observation. Skin color, breathing effort, posture, it's the look phase. You always do this first.
Okay, then palpation. Touching?
Right, using touch. And there are different methods. You have light palpation, which is just depressing the skin about 1 centimeter.
So gentle.
Very gentle. You're assessing surface things, skin texture, temperature. Then you have deep palpation, pressing deeper to feel the organs themselves. And there's bimanual palpation, using both hands to kind of entrap an organ or a mass.
That sounds thorough. Okay, next up is percussion. This is the one that always looks like magic. You're just tapping on them.
It's physics. You're tapping to evaluate the size, borders, and consistency of organs based on the sound they make.
And you're listening for specific tones. The source lists these out.
Definitely. It's all about density. If you are percussing over the lungs, you want to hear a tone called resonant.
And resonant sounds like what?
The slide says loud, low pitch, long duration, and hollow. Think of a drum. Healthy lungs are full of air, so they resonate.
Okay, and what if you tap over something that isn't full of air, like a bone?
Then you hear a flat tone. It's soft, high pitch, short duration, and extremely dull. Because there's no air to vibrate, it just thuds.
So if you're tapping over a lung, which should be resonant, and you hear a flat sound instead.
Then you know you have a problem. There's something solid or fluid where air should be. Pneumonia, maybe a tumor. That's the clue. That's the detective work.
And finally, the 4th technique, auscultation.
This is listening, usually with a stethoscope. You're listening to the heart, the lungs, the bowel sounds, the normal functional sounds of the body.
So we have inspection, look, palpation, feel, percussion, tap, and auscultation. Listen, that's the standard flow.
Correct. That's the standard flow for most of the physical exam. It ensures you gather all the sensory data you can.
It really is a systematic process. It feels like if you skip a step, you could miss something huge.
That's the danger. The goal is to create a complete picture. You're taking that him subjective story, what they feel, and combining it with the sign objective evidence, what you measure. The nurse is the translator.
Speaking of not missing things, the sources mention one last safety net called the review of systems. What is that?
The review of systems is the final sweep of the health history. It's a systematic approach where you ask about symptoms in every single body system.
So this is different from the chief complaint.
Yeah. The chief complaint is my stomach hurts. The review of systems is the nurse asking, okay, noted, but have you also had any headaches, any blurry vision, any shortness of breath?
So it bridges the gap between what the patient forgets to say and what the nurse needs to know.
Exactly, because a patient might not think their blurry vision is related to their stomach pain, but to the nurse, those two things together might point to a bigger issue, like diabetes. The review of systems makes sure no symptom gets left behind.
It connects all the dots. It's like the detective saying, just one more thing.
It does. It wraps up the detective work so you can hand over a complete file to the care team. It ensures that nothing, slips through the cracks.
Well, I certainly feel more prepared to pay attention at my next checkup. It's fascinating to see the logic behind every single question and every tap of the finger. It really gives you an appreciation for the RN's role. They aren't just observing, they are constantly analyzing and planning.
Absolutely. It's the science of caring in action. The assessment is the foundation of everything.
Well, let's unpack this. It is taking on a whole new meaning today. Thank you for walking us through the toolbox of the nurse.
My pleasure. Always happy to shine a light on the detective work.
And for everyone listening, next time a nurse asks you to describe your pain, remember old carts. Give them the details. Thanks for diving deep with us. We'll see you on the next one.